Sheikh for us, Sheikh al-Tariqa for us here in Egypt. Thanks.
Thank you very much, Professor Mahmoud Al-Ansari, for your kind introduction. Dear professors and colleagues, thanks for your kind invitation. And today I will talk about one of the important topics in the field of endoscopic ultrasound, which is how to optimize EUS guided tissue sample. I have nothing to disclose, and my agenda today will include needle selection, techniques of tissue sampling, tips and tricks of difficult scenarios, and endoscopic and cytopathologic experience. The most important question is the needle selection, whether FNA or FNB. FNA needles are more flexible, with easier manipulation with bended scope, so it is more suitable for uncinate process and fundal masses, and less blood contamination, but it obtains less tissue acquisition and may not be sufficient for immune staining and lack of tissue architecture. More than 20 randomized control studies and more than 10 meta-analyses showed that FNB and FNA are equal regarding technical performance and safety, while FNB is better than FNA regarding tissue adequacy, diagnostic accuracy, shorter procedure time due to fewer passes, and the most important is to obtain enough tissue for molecular diagnosis and immune staining. So can we say that the era of FNA is over? We should admit that most of the centers now are using FNB most of the times. FNA needle is recommended in lesions arise from the pancreatic duct gallbladder wall due to lower risk of bile leakage, and in pancreatic cystic lesions due to its lower risk of cystic wall damage and sampling of ascites. And if we want to do FNA sampling and celiac plexus neurolysis, so we use FNA needle. And transvascular biopsy, very rare to do because it is dangerous, and in lesions close to vessel or vascular encasement or highly vascular lesion, because sometimes following FNB we can see some minor bleeding, what is called is patent tract sign. This is the needle track, and after withdrawing the needle we can see some bleeding, but very minimal, and starting a small hemangioma, but fortunately enough, more than 99.9% of cases the bleeding is very trivial and did not produce any hemodynamic instability. EUS needles, the first generation was true cut needle, but it's now not widely used, and the second generation is a reversed bevel needle, and the third generation, I think we are all now using one of them, which is fork tip or sharp core needle, Francine needle, acquire, and forward facing level needle from Cook. Francine needle, fork tip, and forward bevel needle are superior to reversed bevel, of course. And Francine needle and fork tip are comparable. Regarding Procore needle from Cook, forward bevel needle 20G is superior to reverse bevel needle 2220 and 25G. However, due to the heterogeneity and low quality of studies recruited in many meta-analyses, specific recommendations cannot be made. What is the size of the needle preferred? Theoretically, larger needles can obtain a larger amount of material. However, transduodenal EUS tissue acquisition with 19G needles was inferior to the 22 needle with higher technical failure, of course, because the echo endoscope is markedly bended in the second part, so it may hinder the passage of 19G needle. Most endosonographers tend to prefer 22G needle and 25G needles for solid masses, especially with transduodenal approach. 19G FNA is preferred in cyst aspiration with thick fluid content. What is about the technique? Suction and low pressure. Suction may damage the cellular structure and result in blood contamination with less vascularity. While low pressure or slow, what is called also slow pull and capillary, the slow pull technique minimizes negative pressure by removing the stylet itself from the needle slowly and continuously, so less blood contamination, and the rate of a good or excellent cellularity is highest. However, the overall rate of adequate core was not statistically different. Wet suction has better histology, adequacy, and less blood contamination than standard suction. Stylet or no stylet technique. The presence or absence of a stylet has no impact on the specimen adequacy, cellularity, diagnostic yield, and contamination of blood. However, the use of a stylet may reduce the contamination with cells from the gut wall and protects the scope channel during introduction of the needle. Now, to use suction or not to use. Our practice in Cairo University is to apply Doppler first. If the lesion is hypervascular, like lymph node or neuroendocrine tumor or pseudopapillary or cyst, we start with low pressure to minimize blood contamination. And accordingly, if the specimen is scanty, the second pass we will apply suction. And on the opposite, if the lesion is hypovascular, like most cases of pancreatic adenocarcinoma, we start with suction to obtain adequate tissue. And according to the first pass, if it is bloody, then the second pass will apply low pressure. Direction, aspiration direction. The most important item in obtaining adequate fluid is the fanning technique. It increases the accuracy from 60 to 80%. We can do fanning technique by downward movement of the big wheel, or by the elevator, or by gentle push of the scope. This is the needle tract, and then by the elevator we can change the direction of the needle to get tissue from many parts, or more than one part of the lesion. Now we should talk about rules, rapid on-site evaluation. Advantages is it improves diagnostic yield from 85% to more than 90%, and decreases the number of needle passes required for a diagnosis, and reduces the needle of repeating the maneuver. However, it is high cost. It adds to the cost of the maneuver and prolongs the procedure time, and may not be available in most of the time. And of course, it needs experienced cytopathologist. But roles have a role in the following situation: during the learning phase of endoscopic ultrasound, FNA, FNB, at centers in which specimen adequacy rates are below 90%, it should be 95 or more, or if the first specimen was inconclusive in high suspicious lesion, then the second biopsy you should provide rows. What are the options in the absence of on-site cytopathology? We should increase the number of dedicated passes, and now very recently we should depend on using FNB with MOSE. MOSE is macroscopic on-site evaluation. MOSE is the assessment of the adequacy of core specimen for histopathological diagnosis by the endosonographer himself during EUS FNB. FNB with MOSE has a comparative diagnostic yield to rows, and it reduces the number of passes. And now there is a new concept of replacing rows with FNB and MOSE. Many classifications of MOSE are there. The most important and the most informative, I think, is that score. Score 0 is no material. Score 1 is just hemattic or necrotic material. We should repeat it several times if it's score 1. Score 2 is the presence of grayish cores, but shorter than 3 millimeter, 1 or 2 millimeter. Score 3 is the best score in which the grayish-white or yellowish-white cores is longer than 3 millimeter. If we obtain that, then we should suspect adequate sample. Now going to some of the tips and tricks during FNA, FNB. In lesions of the gastric fundus or uncinate process and the endoscope is bended, we sometimes are unable to pass the needle. Then don't force, or you will damage the scope. Just straightening with the scope before inserting the needle, and then after insertion of the needle, you can direct yourself to the target. And of course, use small flexible needles, 25 or 22. This is, I think, one of the most important tips and tricks during FNB. I use it several times, and it is working. This is very high benefit in small hard lesion in a soft organ. This is a small lesion in the pancreas, and this is the needle. Now we're puncturing, passing through the normal pancreas, and here at the upper part of the needle, upper part of the tumor, it is very hard, preventing entrance of the needle. And now I am shaking, just shaking the needle, not moving inside the needle. Here I can apply door knocking technique. I fix the stopper 1 centimeter, the size of the mass, 1 centimeter below the handle, and then by several forcible pushes, I can push the needle. The needle is now pushed inside the mass and moving inside the mass, not just shaking the mass. This small mass was finally proved as small, very small adenocarcinoma, and the patient underwent radical surgery, and he's now doing well because of early diagnosis of this small lesion. Another trick is to obtain biopsy from the hypoechoic area of the mass, not from the center or the hyperechoic, because in the center this hyperechoic area may be blood, may be necrotic area. So try always to obtain from the periphery of the needle, from the periphery of the mass, from the hypoechoic area of the mass, not from the central necrotic area of the tumor. If there is mass and chronic pancreatitis with pancreatic duct stones or pancreatic duct stent, try to avoid the stent, avoid the stone, avoid calcified area. Find transition point of pancreatic duct and common bile duct, very important. The site at which there is sudden change of the caliber of the duct. Here you should suspect the presence of a pathology. And apply elastography, of course, may be helpful, and always use Mohs. If Mohs is satisfactory, then okay. If it is not satisfactory, grade 0 or 1, you should repeat it several times to obtain enough sample. Tissue handling. Prepare both alcohol-fixed slides and formalin block. Use liquid-based cytology if available. It is a very expensive device, may not be available in most of the centers. And the most important, I think, pathologists should be informed about the clinical and biochemical radiological findings before histological examination. And much more important, I think that pathologists should be specialized and experienced in cytopathology. This is big difference between the usual pathologist, the accuracy is 55, and specialized cytopathologist, the accuracy is more than 90%. And I think that the good specimen is due to the proficiency of the cytopathologist rather than the proficiency of the endosonographer. Upcoming channel, the role of molecular analysis and immunophenotyping and genomic characteristics are growing for better analysis of EUS FNB specimen. And now to take home messages, 22G needle FNB, use it first. More flexible FNA needles may be needed in difficult locations. And Francine fork tip and forward bevel are both equal, and they are a little bit more adequate than reverse bevel. Fanning increases accuracy from 60 to 80%. Different aspiration techniques, stylet slow pull first in hypervascular lesion, suction method first in hypovascular lesion, and the second pass is according to the Mohs of the first part, as I mentioned before. Avoid puncturing necrotic areas. Door knocking technique is very helpful in small, firm, distant lesions. Use rows if available. Mohs should be always applied. Mohs with FNB is a good alternative to Mohs. Formalin fixation is preferred in addition to conventional slides. Liquid-based cytology is excellent if available. And the most important is that pathologists should be informed about clinical biochemical and radiological findings before histopathologic examination. And I think the most important point is pathologists should be specialized and experienced in cytopathology. And finally, repeat EUS FNB in highly suspicious solid pancreatic lesions if the first one was inconclusive, and in this situation, try to provide MOS. And thanks for your attention.
شكرا دكتور حسين للاكسلنت توك وبرزنتيشن از يوجوال. دكتور حسين اشكرك جدا طبعا. دكتور حسين لنا سؤال دايما بنقوله، هل النهارده في البنكرياتيك ليجن وتفر هي مالجنت ليجن وخلافه، حاول نعمل يعني هيد ان هيد كومباريزون بين كات سكان وذ كونتراست اند اي يو اس، خصوصا
اخر حته
كات سكان وذ كونتراست اند اي يو اس ماتش انفورميشن او داتا، خصوصا في الكانسر او كرونيك بنكرياتايتس اند سو اون. يعني نخلي بتاع الاي يو اس كجاسترونتولوجي يدينا الانفورميشن داتا، ولا نعتمد على الانترفنشن راديولوجي كات سكان وذ كونتراست وياخد بايوبسي which is which؟
لا هي
give us information data much more.
There are 2 points in the diagnosis and in histopathology.
Yeah.
There is a very well algorithm
Yeah.
all over the world. Just with first we start with CT with contrast or
Yeah.
MR with contrast plus MRCP.
Yeah.
This is the first.
Yes.
And after that,
هيدينا انفورميشن داتا about surrounding structure, lymph node, rounded vessel and so on.
Yes.
It must much more uniform and expanded data.
and accordingly,
Yeah.
if the CT or MRI revealed locally advanced unresectable tumor, then we should do EUS with FNB for possible chemotherapy.
Yes.
But if the lesion is resectable by CT or MRI, we can go forward for surgery. We may need, we may not need FNB EUS guide. If the lesion is borderline, then we should go to EUS for more confirmation. And according to the EUS findings, if it is locally advanced, then should be histopathological, FNA, FNB for chemotherapy. If it is resectable, then go for surgery. So there is an algorithm, and both are complementary and not competitive.
This is my decision making. Is a complementary and not replacing each other.
Yes,
So,
of course.
and before you start to much, you know all the data about the clinical picture and laboratory finding and about all the data about the patient before starting any US maneuver, about his liver condition, about coagulation profile and so on.
Yes, yes, of course. Yes, of course. All are complementary.
Yes. Thank you very much. Any other questions? One is very important topic. تفضل.
I have a question.
No. Now just off Dr. Hussein.
I have a question for
Just off Dr. Hussein now.
نو انا قلت بعد
لا لسه دكتور حسين بس.
شكرا دكتور حسين. انا مش قصدي السؤال للدكتور حسين، انا كنت اسال
في اخر الجلسه لو سمحت.
اوكي.
I have a question
شكراً.
for Professor Hussein. Many thanks for such nice talk. Regarding lymph node sampling, are there any tips for maximizing the diagnostic yield? Yani sometimes the cytopathologist tell us that the sample is bloody and they can't determine the origin for the lesion, and they need more core for to do immunohistochemical stain. And as you know, Professor, sometimes we don't have, especially in proximal CBD structures, and we are suspecting skin tumor. We don't find any lesion except the lymph nodes,
The lymph node,
both
yes.
hepatic lymph nodes.
Yes.
And finally, we don't go for diagnosis.
For lymph node, you just use the 2 tips which I mentioned in my lecture. The first one is don't apply suction. You can do it by low pressure, capillary technique, because the lymph nodes are vascular. If you apply suction, you will have a bloody sample and it will be inconclusive. So don't apply suction with lymph nodes.
We use a capillary method.
No
only.
stylet or low pressure or capillary, no high pressure. This is the first one. And the second one, after you obtain the first pass, you can apply MOS, macroscopic on-site evaluation. If it is stage grade T2 or 3, you have yellowish-white cores, then do the second pass and enough. But if you have 1 pass or second pass or third pass and you still do not have a good MOS, you do not have yellowish-white cores or grayish-white cores, you can do the 4th one and the 5th one and the 6th one. till you obtain good MOS. So the most important two advices or two tips: first, no suction, low pressure, no suction,
Capillary method only.
and then apply MOS. And don't leave the patient except you have a good MOS. You will have.
The type of the needle, fine needle or
22
FNB or FNA or
No, FNB.
FNB?
Fine needle biopsy. We are now using fine needle biopsy, not aspiration, especially in certain situations which I have mentioned. So FNB is the best.